Have you ever ignored a warning that could have saved a life? I'm a nurse with 15 years of experience, and I learned the hard way that pride and arrogance can cost everything. This is the story of how a resident doctor mocked my experience, laughed in my face when I tried to warn him about a critical patient, and how, minutes later, that heart monitor started screaming in a way I'll never forget. What happened that night in the ICU changed my career forever and made me question whether I truly belonged in nursing. Comment what you would have done in my place. My name is Laura Bennett, and I'm 38 years old. I've been a registered nurse for 15 years, working in intensive care units across Portland, Oregon. When I started this journey, I was 23, fresh out of nursing school, filled with idealism and dreams of making a difference. I thought saving lives would be straightforward, noble, pure. Reality hit me hard and fast. The ICU is where hope and despair dance together every single day. I've held hands of dying patients, celebrated miraculous recoveries, and learned that medicine is never black and white. My career cost me my marriage 5 years ago. My ex-husband couldn't handle the overnight shifts, the emotional baggage I brought home, the times I missed our kids' school events because someone's grandmother was coding. I have 2 children, Emma and Jake, now 12 and 10. They live with their father most of the time, and that guilt never leaves me. But nursing isn't just what I do, it's who I am. I've learned to trust my instincts, that sixth sense that develops after years of watching subtle changes in patients that others miss. The hospital where I work is a level 2 trauma center, always busy, always demanding. The ICU is a maze of beeping monitors, ventilators, and that distinct smell of antiseptic mixed with something indefinable, something between fear and determination. Portland's rainy nights make the hospital feel even more isolated from the outside world, like we're in our own universe, where life and death decisions happen every hour. If this story has already grabbed your attention, go ahead and subscribe to the channel now, because what comes next will surprise you even more. And comment below, where are you watching this from? I love connecting with people from all over who understand what it's like to fight for what's right. It was a Saturday night in late October, one of those typical Portland evenings where the rain doesn't just fall, it attacks the windows with vengeance. The ICU was running on a skeleton crew, something that happened too often on weekends. Just 4 nurses for 12 critical patients, which meant we were stretched dangerously thin. I was assigned to the cardiac wing, monitoring 4 post-surgical patients recovering from various heart procedures. Around 8 p.m., a new face appeared in our unit, Dr. Marcus Chen, a third-year resident who had just transferred from a prestigious East Coast medical school. He walked in with that swagger some young doctors have, the kind that screams Ivy League education and unshakable confidence. He was 29, tall, with perfectly styled hair even at night, and expensive shoes that clicked against our worn hospital floors. From the moment he introduced himself, I felt the tension. He had that look, the one that says he believes nurses are just there to follow orders, not to think. During our handoff meeting, I mentioned concerns about standard protocols for our cardiac patients, suggesting we monitor certain parameters more closely given the weekend staffing situation. He cut me off mid-sentence, smiled condescendingly, and said that he'd been trained at one of the best programs in the country and knew exactly what needed to be done. The other nurses exchanged glances. We'd seen this type before. Among our patients that night was Mr. Harold Williams, 72 years old, recovering from a complex coronary artery bypass graft surgery performed 3 days earlier. He was stable according to the charts, but I'd been watching him since my shift started. Something felt off in a way I couldn't quite articulate yet. Around 9:30 p.m., I was doing my routine checks when I noticed Mr. Williams seemed different. His vitals on the monitor looked acceptable at first glance. Blood pressure at 120/75, heart rate at 82, oxygen saturation at 96%. But I've learned that numbers don't tell the whole story. His skin had a subtle grayish pallor that wasn't there an hour before. His jugular veins looked slightly distended when he turned his head. His breathing, though regular, had this quality I can only describe as effortful, like he was working just a bit harder than he should be. I placed my hand on his wrist to check his pulse manually, something old school nurses still do, and it felt thready, weak, despite what the monitor said. I increased the frequency of my checks, going into his room every 10 minutes. Each time, these subtle signs became slightly more pronounced. His blood pressure started showing small fluctuations, nothing dramatic, just dropping to 115/70, then 110/68. His heart rate climbed slowly to 88, then 92. These weren't alarming numbers by themselves, but the trend worried me deeply. In cardiac post-op patients, especially after the type of surgery Mr. Williams had, these patterns could indicate fluid accumulation around the heart, a condition called cardiac tamponade. It's rare but catastrophic if missed. I'd seen it twice before in my career, and both times it started exactly like this, with whispers of trouble that gradually became screams. I knew I needed to alert Dr. Chen immediately, but I also knew what was coming. Still, Patient safety comes first, always. I found him at the nurse's station, chatting with Melissa, a young nurse who'd started just 3 months ago and was clearly impressed by his credentials. Thank you for staying with me this far. It shows you feel the same thing I felt when I lived through all of this. So go ahead and subscribe and turn on the notification bell, because what comes now changes everything. Dr. Chen, I need you to examine Mr. Williams in bed 7, I said, keeping my voice calm and professional. He looked up from his conversation, slightly annoyed at the interruption. What's the issue? His vitals look fine on the monitor. I explained what I was observing, the subtle changes in skin color, the jugular vein distension, the blood pressure trend, the quality of his breathing. I suggested we might be looking at early signs of cardiac tamponade and should consider an echocardiogram to check for pericardial effusion. He actually laughed. Not a chuckle, but a full laugh that made Melissa giggle nervously. Nurse Bennett, I appreciate your concern, but I've reviewed Mr. Williams's chart thoroughly. His surgery went perfectly, his post-op course has been textbook, and frankly what you're describing sounds like normal post-surgical recovery. The monitors are stable. I think you're being a bit paranoid. The words stung, but it was the dismissive tone that really cut deep. I felt my face flush with humiliation as other staff members pretended not to notice the exchange, but 15 years of experience had taught me to trust my gut over someone's ego. Dr. Chen, I've been doing this for a long time, I said, my voice firm now. I'm formally requesting that you physically examine this patient. Something is wrong. His expression hardened. Look, I respect that you have experience, but let's be clear about roles here. I'm the physician. You're the nurse. The monitors show stable vitals. Leave the diagnostic medicine to those of us who went to medical school, okay? He turned back to Melissa, effectively dismissing me. I stood there for a moment, anger and doubt warring inside me. Was I overreacting? Were my instincts failing me? But then I remembered Mr. Williams' face, that subtle distress, and I walked back to the computer and documented everything in meticulous detail, noting the time, my observations, and Dr. Chen's refusal to examine the patient. If something went wrong, there would be a paper trail, and the next 20 minutes were the longest of my life. I couldn't shake the feeling of impending disaster, like watching a car accident happen in slow motion. I went back to Mr. Williams' room and rechecked everything. His blood pressure had dropped again, now 105/65. His heart rate was 98, still within acceptable ranges technically, but the trend was undeniable. Mr. Williams, how are you feeling? I asked gently. He gave me a weak smile. I'm okay, nurse. Just tired. A little hard to catch my breath, but I figure that's normal after heart surgery, right? I adjusted his pillows, trying to make him comfortable while my mind raced. That difficulty breathing, combined with everything else, was another red flag. I wanted to call Dr. Chen again, but I knew how that would go. I considered going over his head, calling the attending physician at home, but that nuclear option could have serious consequences for my career if I was wrong. The ICU that night had an eerie quality to it. Most patients were sedated or sleeping. The usual chaos was replaced by an unsettling quiet, broken only by the rhythmic beeping of monitors and the whoosh of ventilators. I found myself standing at the nurse's station, staring at Mr. Williams's monitor from a distance, willing it to stay stable. Dr. Chen was in the break room now. I could see him through the window, feet up, scrolling through his phone with complete confidence. Melissa walked by and gave me a sympathetic look. You okay, Laura? I nodded, but didn't trust myself to speak. Was I losing my mind? Had I become one of those paranoid, experienced nurses who sees disaster around every corner? But then I remembered my training, my years of pattern recognition, and I absolutely knew, something was going catastrophically wrong inside Mr. Williams's chest. Now I want to hear from you. Where are you watching this story from? Write it in the comments. It's incredible to see people from so many places following stories like this. And if you haven't subscribed yet, do it now. You won't regret it. At exactly 10:07 p.m., the silence shattered. The heart monitor's alarm erupted with that distinctive, terrifying sound that every ICU nurse knows in their bones. I was already running before my conscious mind registered what was happening. I burst into Mr. Williams' room and saw the monitor screen showing ventricular tachycardia rapidly deteriorating into ventricular fibrillation. Mr. Williams was unconscious, his skin now obviously gray, no pulse at his carotid artery. Code blue. ICU bed 7, I shouted, simultaneously hitting the emergency button on the wall. I immediately started chest compressions, positioning myself properly, locking my elbows, pushing hard and fast on his sternum. The compressions cracked through the terrible silence. Within seconds, other nurses appeared. Sarah grabbed the crash cart. Melissa started documenting. Another nurse prepared medications. Dr. Chen came running from the break room, his earlier confidence completely evaporated, replaced by pure panic. I saw his hands shaking as he approached. What happened? He stammered. Exactly what I told you would happen. I wanted to scream, but this wasn't the time. He's in VFib. We need to shock him now. Charging defibrillator to 200 joules, Sarah called out. I continued compressions, counting aloud, 30 compressions, maintaining the rhythm that could be the difference between life and death. Clear. Everyone stepped back. The shock delivered, Mr. Williams' body jerked. We all stared at the monitor. Still V-fib. Resume compressions, I ordered, immediately starting again. Someone hand me the amiodarone. Melissa prepared the medication with trembling hands. Dr. Chen stood frozen, his face pale. This wasn't a textbook case anymore. This was real, messy, terrifying reality. Push 1 milligram of epinephrine, I said, and Sarah administered it through the IV line. My arms were burning from the compressions, but I didn't stop. Couldn't stop. 3 minutes into the code, we shocked him again. 200 joules. Clear. Another jolt. Another desperate glance at the monitor. Still V-fib. I resumed compressions immediately, sweat dripping down my face despite the cool hospital air. We need to consider pericardiocentesis, I said, looking directly at Dr. Chen. If this is tamponade, we're running out of time. He nodded mutely, finally understanding the gravity of his earlier dismissal. By now, the night attending, Dr. Patricia Morrison had arrived, a woman in her 50s with gray hair and 30 years of emergency experience. She took one look at the situation and took command. How long has he been down? 4 minutes and 30 seconds, Melissa reported from her documentation station. History? Dr. Morrison asked, already pulling on sterile gloves. I gave her a rapid-fire summary while maintaining compressions, including the subtle signs I'd observed for the past hour and Dr. Chen's dismissal of my concerns. Her jaw tightened, but she focused on the patient. We're doing an emergency pericardiocentesis. Get me the kit now. Sarah had it ready within seconds. Another shock, this time at 300 joules. Brief pause, then back to compressions. My shoulders screamed in protest, but another nurse, James, tapped me to take over. I stepped back, gasping, watching as Dr. Morrison prepared to insert a needle into the sac around Mr. Williams's heart. This was a procedure with razor-thin margins for error, done at bedside only in the most desperate circumstances. She positioned the ultrasound probe, finding her landmarks with practiced expertise. There, she said, pointing at the screen. Massive pericardial effusion. Tamponade confirmed. She inserted the needle at a precise angle, aspirating slowly. Dark blood filled the syringe, the fluid that had been crushing Mr. Williams's heart. Suddenly, the monitor changed. The chaotic rhythm began organizing itself into something more recognizable. Con, we got organized rhythm. Check for a pulse, Dr. Morrison commanded. I placed my fingers on Mr. Williams' carotid artery and felt the most beautiful thing in the world. A weak but present pulse. Pulse present, thready, but there. Spontaneous breathing? Not yet. Bag him. Maintain oxygen. The next 10 minutes were a carefully choreographed dance of medications, monitoring, and cautious optimism. Mr. Williams's heart rhythm stabilized. His blood pressure slowly climbed. Color began returning to his face. Dr. Morrison drained nearly 300 milliliters of blood from his pericardial sac, explaining that post-surgical bleeding had caused the tamponade, exactly as I had suspected. He needs to go back to surgery now to find and repair the bleeding vessel, she said. Call the cardiac surgeon. Get the OR ready. As the team wheeled Mr. Williams toward the elevator, Dr. Morrison pulled me aside. I read your documentation, she said quietly. You called this an hour ago. I nodded, unable to speak past the lump in my throat. Good nursing, Laura. Your assessment saved his life. When she left, I found myself standing alone at the nurse's station, adrenaline still coursing through my veins, hands trembling with delayed reaction. Dr. Chen approached slowly, his earlier arrogance completely gone. Nurse Bennett, I'm so sorry. I should have listened. I should have examined him. This is my fault. I looked at him. This young doctor who had been so confident hours earlier, now confronted with the reality that his ego had nearly killed someone. Part of me wanted to rage at him, to make him feel the full weight of his dismissiveness, but I was too tired, and honestly, I remembered being young once too, though I'd never been that arrogant. Chapter 9. The next 72 hours were a blur of meetings, statements, and emotional exhaustion. Mr. Williams survived the emergency surgery. They found and repaired a small bleeding vessel near his bypass graft site. He remained critical but stable in the ICU, slowly improving each day. I visited him when he was conscious enough to understand. Thank you, he whispered, his daughter holding his hand and crying. The nurse told me you saved my dad's life. I just did my job, I replied, but his daughter hugged me so tightly I thought my ribs would crack. On Monday morning, I was called to a meeting with the nursing supervisor, hospital risk management, and the chief of medicine. They wanted my detailed account of everything that happened that night. I provided my documentation, explained my observations, the timeline of events, and Dr. Chen's dismissals. The risk management director, a stern woman named Catherine, read through my notes carefully. Your documentation is exemplary, Nurse Bennett. Very thorough. I learned that Dr. Chen had a history I wasn't aware of. 2 complaints from nurses at his previous hospital hospital about dismissive behavior and failure to respond to nursing concerns. Nothing serious enough to derail his career, but a pattern nonetheless. The hospital system protects doctors, sometimes at the expense of nurses' voices. The chief of medicine, Dr. Raymond Hughes, looked uncomfortable. This is a serious matter. We're conducting a full review of Dr. Chen's clinical performance and interpersonal conduct. The nursing supervisor, Maria, who'd been my advocate for years, spoke up. This also highlights a bigger issue about how nurses' clinical assessments are valued in this hospital. We need systemic changes. Over the following weeks, I learned that Dr. Chen was placed on probation and required to undergo additional training on interprofessional collaboration and communication. 3 weeks after that terrifying night, something unexpected happened. I was finishing a day shift when Dr. Chen approached me in the hallway. He looked different somehow, humbled, more human. "Nurse Bennett, do you have a moment? We found an empty consultation room and he closed the door. I've been wanting to talk to you, but I didn't know what to say. I've spent these weeks thinking about that night constantly. I could have killed Mr. Williams because of my ego, because I valued my pride over your experience." There were tears in his eyes, genuine remorse that I hadn't expected. I've been required to do all this training about teamwork and communication, but the real lesson was watching you that night. You never gave up on that patient, even when I humiliated you. That's what a real healer looks like. I didn't know how to respond at first. Part of me was still angry, still hurt by his dismissiveness, but I also saw something I hadn't expected: growth, genuine transformation. "We all make mistakes," I finally said. "The question is whether we learn from them." Since that night, things changed in our ICU. The hospital implemented new protocols requiring physicians to respond to nursing concerns within 15 minutes and document their clinical reasoning if they disagreed with nursing assessments. It wasn't perfect, but it was progress. Mr. Williams recovered fully and was discharged home with his daughter. He sent me a card that I keep in my locker, thanking me for trusting my instincts. Dr. Chen and I developed a respectful working relationship. He became one of the residents who actually listened to nurses, who understood that experience matters, that healthcare is a team effort. As for me, that night reminded me why I chose nursing despite all the sacrifices, the missed birthdays, the divorce, the emotional toll. Because sometimes, standing your ground and trusting your training is the difference between life and death. Because advocacy isn't always comfortable or appreciated in the moment, but it's always necessary. I'm still here in the ICU, still fighting for my patients, still trusting that voice inside that says something's wrong, and I'll never stop, because that's what nurses do. We stand in the gap between suffering and healing, between death and life, and we refuse to be silenced, no matter who's laughing at us. And that was the night that almost made me quit nursing, but in the end reminded me why I chose this profession. I want to hear from you. Have you ever been in a situation where you weren't taken seriously at work? How did you handle it? Write it in the comments. I love reading each one of your stories. If this story touched you in some way, subscribe to the channel for more real stories from the life of those who are on the front lines of healthcare. And don't forget to click on the next recommended video, because there's another story that will leave you speechless. Thank you for staying with me until the end. See you next time.